Hi, everyone. Welcome back. Today, we're joined again by Dr. Stenehjem to give our weekly update to the community on COVID-19. It's been about 2 weeks since the last time we spoke, so we have a lot to discuss and go over. Dr. Stenehjem, as always, thank you for joining us.
You got it. Thank you.
I want to start with case trends and just kind of go over what's been happening since the last time we spoke. Utah has a total of 209,170 total cases in the state. Our daily case count for today was 3,005, which brings us to a 25.2% 7-day rolling positive average. Our total deaths in the state are 925, and we had 8 today. Our hospitalizations are at 8,625, and there's a total of 587 people in our hospitals right now. Let's break that down a little bit. How are hospitals doing? What have we been seeing since the last time we spoke?
Yeah, it's really complex in terms of the data on cases right now. What we saw as we kind of entered into the Thanksgiving holiday week is starting that Saturday, Sunday, into Monday, we started cases starting to go down. And we think that that likely was due to, the governor mandate that was 2 weeks prior to that in terms of decreasing extracurricular activities and social events. We saw those kind of low case counts go in through Thanksgiving, but the challenge with the Thanksgiving holidays, that Thursday, Friday, Saturday, Sunday, is we also had really low cases. We really had low number of testing. And so we saw testing go way down, our test percentage, test positivity go way up. And so it's really hard to make a ton of sense, what was happening in that period because we had such a low test volume, but yet we had a high test percentage. But I think we can say that we saw cases come down likely due to the governor's mandate. And now we're starting to see the tests come back up. When we look at what happened, we're 2 weeks out now from the beginning, almost 2 weeks from the beginning of the Thanksgiving week, where those mandates were taken away. And so there wasn't any recommendation in terms of social gatherings, no mandate from that standpoint. We relaxed those guidances. And now we're starting to see cases go back up. And so today we had 3,000, yesterday we had about 4,000. So we're starting to see these cases come back up. I don't think we're seeing yet the impact of the Thanksgiving Day holiday, Thursday, Friday, Saturday, Sunday of last week. So we're about 7-8 days out from Thanksgiving. Usually when we started seeing cases go up from a holiday, we're usually looking around days 10 to 14, somewhere in that area. So we're going to have to watch really closely. We anticipate this probably pretty sizable wave of infections that are going to come after Thanksgiving, we think. We're prepared for that. When you look at hospitalizations, what has happened is that the census went way up, and now it's remained stable. There's been some fluctuations day to day, but relatively stable over the past couple of weeks in terms of hospital volume. Now, this isn't hospital volume that we're comfortable with. We're still above the 85% capacity in our referral ICUs. We're very, very busy. You're seeing the proportion of ICU patients making up that capacity go up. And so we're still in a spot where we are really not well positioned to tolerate another surge, which is likely coming from Thanksgiving. Keep in mind, we'll first see cases go up post-Thanksgiving, potentially as early as this weekend into next week. Cases go up 7 days later or so, we'll see hospitalizations go up. And so we're in a pretty tenuous spot right now in terms of case counts and hospitalizations, just essentially kind of waiting for this big wave of cases from Thanksgiving to hit us.
I want to touch really quickly on last week. You mentioned that testing was down and therefore our cases were down. Do you think this is for a specific reason at all? Was it because of the holidays? Why was our testing down so much the last week?
Yeah, I think it's due to a number of reasons, but keep in mind a lot of our testing centers were closed on Thanksgiving Day. And so we had closure of some testing centers. We had people, on holiday, potentially with families. And then we always know that our testing goes down on the weekends and Saturday and Sunday. So I think it's just the nature of, people are willing to stay home, not get tested right away. And then on top of that, we had testing centers that were closed. And so I think all of that contributed to low testing numbers. But when you look at our test positive percent, went up to 39% one day, which tells you that, the population of those being tested is different. These are people that are more likely to be positive. And so they're really focusing on people that, hey, I'm really sick. I don't know what I've got. I better go get tested, versus those that are like, I can push it off. And I think that's what was reflected in the numbers.
And how are our caregivers doing? What has their lives been like the last couple of weeks? Have things gotten easier in the ICU or better for them at all? And how is their morale doing?
Yeah, I definitely won't say that things have gotten easier. What you can see in the ICUs is that we've expanded our ICU capabilities. Just at Intermountain Medical Center, we have the respiratory ICU and the shock trauma ICU. Respiratory ICU is full of just COVID patients. We've expanded our ICU into one of our cardiac floors. And so we've taken a general medical floor, converted part of it into ICU rooms. Now our COVID patients are overflowing into that ICU and also into the cardiac intensive care unit, into the neuro ICU. And so we've kind of reached a steady state in terms of patient volumes. They go up a little bit, they go down a little bit. We're still load balancing across our entire system. So we have dozens of patients at Utah Valley and McKay and St. George, Riverton, Altaview. All of our hospitals are essentially operating to their max capacity from an ICU standpoint to really accommodate all of these patients. Our health caregivers are tired, they're fatigued, and they're worried about what's going to happen in the next, really 2 weeks. And then you throw on Christmas, which then potentially has an impact into January of 2021 in terms of our ICU capacity. And so I think what they're looking at is this realization that we are going to be operating at this max capacity for at least another couple months, and things are probably going to get worse, unfortunately, because of these holidays. And that's just unfortunately the reality. So yeah, they're rock stars, but they're tired, they're frustrated. And keep in mind, we're bringing in new nurses, new physicians, new advanced practitioners to take care of these patients. Just today, I was on COVID rounds, and one of the physician's assistants that were managing these floor patients of COVID came from an outpatient clinic and said, yeah, I'll step up and I will take a turn in the COVID unit. And he got brought up to speed, got educated, has great oversight. But that's an example of a redeployed caregiver, somebody who usually operates in the clinic, taking care of general internal medicine patients, now being pulled into the hospital to take care of very sick COVID patients on the medical floor.
I want to ask you a really quick question before we get into holiday suggestions for Christmas. You mentioned we're seeing lots of cases currently right now. Are we seeing anything else? It's not yet flu season, but is there anything else circulating in the community that you're aware of that people need to be looking out for? Or are we still only seeing COVID cases?
Yeah, we are looking and keeping really close eye on the influenza activity in the greater Utah area. We look at this on a week-by-week basis. We saw 2 cases of influenza B in kids back in October. We haven't seen any cases of flu in November and none yet in December. So not seen flu A, not seen flu B, not atypical. December is really the time when we start seeing cases of influenza. We'll continue to watch for that very aggressively. And the other thing to be said is we're testing for it. We're looking for it. We have a number of different tests we can use for influenza, which is a very different test than the SARS-CoV-2 test. Haven't seen it. RSV is something we're obviously really looking for, especially in children. Haven't seen a rapid rise in that either. And then we see a smattering of kind of seasonal cold viruses, the seasonal coronavirus, being a couple of them. Really not seeing big spikes in those at all. When you look at the epidemiology of viral infections currently in Utah, COVID by far and away dominates.
I'm also assuming people aren't going to like an urgent care or something for the common cold. Those are kind of things that you can figure out on your own. Is that correct?
So we definitely have seen our urgent care volumes take a significant nosedive right in that April, May area. They've come back, but they haven't hit back to usual volumes. And to your point, I think it's kind of a mixed bag of this. Keep in mind, people are wearing masks, people are social distancing. There's so many people in Utah that are doing just an amazing job at this. And what that does is that decreases viral transmission from other things. from other respiratory viruses. And so people aren't getting otitis media or ear infections. They're not getting sinusitis. They're not getting, pharyngitis, sore throats due to viral infections, just because of the public health measures we have in place for COVID-19. So that's probably driving a decrease in some of our urgent care visits and ED visits. And also potentially there's part of it just saying, listen, I'm going to suffer this out. I'm going to take over the counter remedies. I'll only go in if it gets bad. And then we're also seeing a really big, continued rise in our Connect Care, our direct-to-consumer telemedicine platform as well. So I think they're finding different ways to get care, and some are just not getting sick because we're doing social distancing and masking.
Someone just asked us a question about COVID restrictions and the significant increase of cases we had a couple of days ago. The COVID restrictions were in place until the Monday before Thanksgiving, and there's a couple of lag days to a couple of weeks. But why do you think those numbers were so high that day where we had that 49% day, if it was the most stringent restrictions we've had so far in the state?
Well, so I think they're talking about the days right around Thanksgiving where we had really high test positivity.
Mm-hmm.
I think that was a direct result of test referral patterns in terms of people not going to get testing with mild symptoms and only going if they have really pretty significant severe symptoms that are consistent with COVID-19. And so your test, this is the hard part of watching and following test positivity, is that the test positivity is indicative of your denominator. And so it's really, really dependent on your test seeking behavior. So if your test seeking behavior changes, then your test positivity is going to change, even if there's no change in the community. Okay, so, one of the examples we'll use for this is that as we bring in more tests, Governor Herbert has mentioned we want to bring in thousands of tests to be able to go in and test people in extracurricular activities, people that are in sporting events, and college students. As we bring in all of those tests, we're going to flood the market with more tests, which is going to drive down our test positivity just from the nature of testing referral patterns. And so I think that's probably the biggest driver. I do think, though, that those mandates ended about 10 days ago, which is probably why we're starting to see this big rise in cases, which is likely just going to move into the rise that we see from Thanksgiving.
Another quick question for you, and I'm not sure if you know the answer to this or not, but have we had to delay any sort of non-COVID care or procedures or turn patients away because of the rise of cases and hospitalizations?
So, yeah, we haven't had to turn people away, people that are coming into the hospital to seek care for whether it be COVID or non-COVID. We haven't had to turn people away at this point. I would say that Intermountain's being very smart in the way that they're moving forward in terms of their non-emergent surgeries. And so there are going to be, movement moving forward and looking very closely at each individual hospital or whether or not they can continue doing non-emergent surgeries that need an overnight stay. That's going to be a very dynamic process, and it's going to be hospital dependent. And I can tell you our surgical leaders across Intermountain are looking at this daily and making sure that they match the volume of surgical cases to the capacity that they have in the hospital. And the minute they don't have capacity, they're going to turn the dial off on those non-emergent surgical cases.
One more question, and then we're going to switch over to the holidays. Do you have any specific information related to the St. George, Dixie region of Utah and how they're doing compared to the rest of the state?
All I can say is that they have in their hospitals very high caseloads. They have a very busy ICU. They're the only major hospital down in Southwest Utah. And so they remain very, very busy. When we look at their their census for COVID patients, it rivals just like any of our other major COVID centers. Their docs are great, and they are doing really kind of collaborative activities to be able to manage these patients. And so what's happening is that some of the neurology hospitalists are stepping up to take care of the COVID patients, and we're sending some of our standard neurologists down to take care of them. They're really coming together as a team to manage these patients. But it's a lot, and their census are high, and it's an area that we watch very closely.
I want to switch over to holidays. As you mentioned earlier, we just had Thanksgiving, and Christmas and Hanukkah and all sorts of gathering holidays are coming up in the next couple of weeks, which is crazy. This year feels like it's been the longest and shortest year ever. Any suggestions for people on what they should do as they think about their holiday plans?
Yeah, I mean, I think we have to kind of forecast forward as where are we going to be, come December 24th and, around the Hanukkah season. I anticipate that we're going to be in a very similar situation for Christmas as we were for Thanksgiving, where our hospitals are at capacity. We have high case counts. I don't anticipate us to be in a better situation. I think if we can kind of look into that magic or crystal ball and say what's going to happen, I think what we'll see is that probably start next week, we're going to start seeing cases go up due to the Thanksgiving Day holiday. That then is going to be followed in 7-10 days with hospitalizations going up. And so now that puts us, in solidly mid-December, right as we are going into, the holiday season. And so I think we're going to be in a very similar situation, if not worse. It all depends on how Thanksgiving drives cases, which I anticipate is going to be worse than the previous holidays, because this is the first holiday we've had where we've all go inside for it. And so I think where we'll be at in Christmas is again, a really tough spot with high case counts in the community, high hospitalization rates. And I anticipate that we're going to be offering very similar guidance for Christmas as we did for Thanksgiving, and the fact that we're going to recommend not socializing with people outside of your home. And that's going to, continue to be really hard on people. And I think that's probably where we'll be through Christmas, New Year, and then we'll have to see what happens, from the Christmas holiday in terms of cases and hospitalizations. But it very well could be a similar pattern to what we saw on Thanksgiving.
I know a couple of weeks ago you mentioned if we can get through the holidays, we can have all these great festivities in the summer where we can get together. So hopefully people think about the positives of potentially getting together in big groups at a later time.
Yeah, and I think a lot of people in Utah heeded this advice, and so I don't want to underplay that. And so many of my colleagues and patients and friends and family across the U.S. all took this very seriously and stayed home and stayed just with their nuclear family in their homes, and that happened all over Utah. And I think we have to say thank you. Thank you to everybody that did that, because we hope that is enough, and we hope that really mitigates or attenuates the amount of cases we see. So to everybody out there that really took this to heart on behalf of their community and on the healthcare systems, we owe you a debt of gratitude.
Yeah, that's a great point. I know there's definitely lots of people who followed those rules and made sure that they were sticking to households only. I want to switch to vaccine conversation really quickly. I want to debunk a couple of myths first, and then just give an overall update on kind of what's going on. We've received a little bit or a couple of comments related to what goes into a vaccine specific to DNA, either from humans or from animals. Can you kind of talk about what is in a vaccine and debunk the fact of these DNA myths that we're hearing?
Yeah, so the vaccines that are coming to market soon, so very soon, potentially within 10, 11 days, Pfizer vaccine and Moderna vaccine, these are RNA vaccines or messenger RNA vaccines. So this isn't DNA, but this is RNA. So what happens is you have DNA, you have RNA develop off of that then gets translated into proteins, and then that gets an immune response developed from it. And so RNA, this genetic material, we make this in the lab. Okay, so we can make RNA. So we aren't taking human DNA, we're not taking animal DNA. This is manufactured RNA in the lab. And then they put it in a vehicle that will allow it to be taken up into the cells. And then that RNA is what we call translated, turned into a protein, and that protein then is expressed, and that's how we form an immune response to that protein, which happens to be the spike protein of SARS-CoV-2. And so, yeah, we're not using, these companies are not using animal DNA, they're not using DNA from humans or from babies. This is lab manufactured RNA that is specifically coded for the spike protein of SARS-CoV-2. The other thing to note is that RNA doesn't get part of your genome. It doesn't get into your DNA. There's no part of this virus DNA or this DNA that is derived in the lab, or RNA that's derived in the lab, that gets somehow inserted into your genome. This is just essentially the blueprint to how to make the protein. And so that then just gets degraded. And so really it's not animal DNA. It's not DNA from humans. This is just lab developed RNA.
I want to talk about safety of this vaccine. There has been lots of reports about the Moderna and the Pfizer one that you just talked about. Can you just talk through the safety precautions and data that's out there? Mm-hmm. And also if we know anything about the short-term side effects of the vaccine as well.
Yeah, so I think what people need to realize is that, these vaccines were developed very quickly. However, we didn't take any shortcuts in terms of safety evaluation. The way that this vaccine was able to move so quickly is that Operation Warp Speed, our federal government, took the risk away from the pharmaceutical companies and brought it on themselves. So essentially what they said is, we're going to fund you to do this work. And so that's the way we can turn up phase 3 studies so quickly. That's the way that we can have vaccine being manufactured as the phase 3 studies go on. That's a huge risk, right? What if that phase 3 study was a negative study? Now you've manufactured millions of doses that you just have to waste. And so that risk was taken on by the government, and that was done very well by Operation Warp Speed. And so there hasn't been any shortcuts from a safety standpoint. Okay, and so in phase 1, phase 2 study, you look specifically at safety. And so you look at how people respond to the virus from an immunologic standpoint, and do they develop any side effects from it. Phase 3, you get a much larger study, and you're now looking at whether or not this vaccine is effective, meaning does it actually do what you want it to do, which means prevent SARS-CoV-2 infection, and is it safe in the population you give it. And so far, 15,000 people in each study have received active vaccine, and we have not seen any serious safety events due to this vaccine. When you look at the vaccine world and that literature going back decades, you typically will see, if you're going to have a vaccine related side effect, you're going to see that within the first 2 months of inoculation. And so that is the reason why the FDA required these pharmaceutical companies to have 2 months of safety data, is that that's when you see serious safety events. And we haven't seen any with the Moderna or the Pfizer vaccine. So that's really good news. Short-term side effects, these vaccines are a little more what we call reactogenic than our traditional flu shot, tetanus shot, pneumovax, things like that. There's a good proportion of people that after the vaccine will feel feverish and achy for 24 to 48 hours. And that's the normal expected response of your immune system and how you're going to feel as you're generating an immune response to this vaccine. And so that should be thought of as normal and almost to be expected. And that typically will last 24 to 48 hours. That's based on the data in the phase 1, phase 2 trials, and what they've released so far in terms of phase 3 as well.
And I know people always mention long-term effects, but you mentioned this, we won't know long-term effects for many, many years, obviously. So I'm assuming there's no way to really gauge if there will be long-term effects necessarily, or is there?
The only long-term effects that we hope to see is people don't get SARS-CoV-2. We don't anticipate there to be any long-term effects. Those kind of long-term effects are called post-marketing analysis, where you have to vaccinate tens of hundreds of thousands of people to see if there's a signal for a safety event that occurs later on. But like I said before, the vast majority, I can't really even think of any of the side effects from vaccines occur within the first 2 months. And so we haven't seen that. And so that's a really good signal that this is a safe vaccine. And so, I have absolutely no hesitation to get this vaccine. And so when I'm up and when it's my turn, I'm going to be right there in line getting the vaccine because of the safety checks that have been put in place, and it looks great.
I just got a question. Do you have any concerns about the vaccine, since we've never used an mRNA vaccine before, at least on a massive scale? And if so, what are they? And if not, why not?
Yeah, so really good question. Keep in mind that we've been studying RNA vaccines going back about 4 years. These are vaccines that have been developed for a number of things: West Nile virus, Zika virus, and they just haven't been used on such a massive scale. This vaccine, has not been used on a large scale. Totally agree. The method that this works is, the method of all vaccines that are protein-based like this, is that you're developing a method to allow your body to see a protein that is from the virus to generate an immune response to then protect you from this infection. And so you're right, this hasn't been used on large scale. However, the data behind it, the science behind it looks really good. And I think this is a vaccine that will be successful. And I think we still have a lot of questions about it. We don't know how long immunity will last. We don't know what are correlates of immunity. Can you follow an antibody response? And is that antibody response, and does that correlate with risk of infection? All of these things we'll have to really get a better handle on as we move forward in these vaccine studies.
You brought up immunity. That was actually my next question. We published an article about herd immunity from Brandon Webb a couple of weeks ago, and someone asked a follow-up question. If we can't expect herd immunity from catching the virus, how can we expect to get it from the vaccine? And also, do we know if this is going to be something we take once a year, every 6 months, every 5 years, et cetera?
So let's just make an assumption before we move on with this part. Let's just make an assumption that getting the infection and getting the vaccine results in the same amount of immunity. Okay, we don't know that to be true, but let's just make this assumption that if you get infected and I get the vaccine, that our immunity will last the same amount of time. Don't know if that's true or not, but let's just make that assumption. The difference is that, a couple other assumptions we have to think of. We also have to say that developing herd immunity is dependent on having long-lasting immunity, lifelong immunity, where you get infected, you're immune for the rest of your life, okay? If you get infected and you're immune for a year, right, then you can get infected again, okay? So there's no ability to generate herd immunity if you don't have long-lasting immunity. And so that's the whole reason why we still have seasonal coronaviruses circulate in our community, and why we get infected year and year and year again with seasonal coronaviruses, because we don't generate herd immunity to respiratory viruses. That's why we get influenza over again, coronavirus over again. So one is, we don't know if we can get herd immunity just because we don't think immunity is going to last that long, okay? The big difference is getting herd immunity from the infection versus getting herd immunity from vaccines is that getting herd immunity from infections results in hundreds of thousands of people dying, versus people getting herd immunity from vaccine, they don't die, okay? And so this idea that, why are you so focused on herd immunity from a vaccine? Well, because that's a safe way to get herd immunity, if that exists, because vaccines don't result in people dying in the ICU on ventilators. Herd immunity relies on people getting sick with SARS-CoV-2, leading to COVID-19, which leads to death and dying and morbidity and mortality and the stress on our healthcare system. Vaccines don't do that. So that is, it's an argument that has no basis at all. Vaccines are safe and they're effective, and they can be given over and over again if needed. And so hopefully that clarifies that distinction. In terms of how long will this immunity last? Again, I know it's an unsatisfying answer. We don't know, okay? When we listen to people that are much smarter than I am about vaccines and immunology, they anticipate that we'll have immunity probably on the order of at least a year or two, if not longer. But we're going to have to really watch these cohorts of people that get vaccinated to see when that immunity wanes and when you start seeing increases in infection. And that would then determine the cadence of how often you need to be vaccinated. The nice thing about the SARS-CoV-2 virus in comparison to the flu virus is that the spike protein isn't as variable in terms of developing mutations in it as the influenza virus. The reason we have to get influenza vaccines over and over again is that virus changes. It changes every year, and so then we have to get vaccinated against a new strain. Whereas in SARS-CoV-2, we think that spike protein is pretty well conserved, meaning it doesn't change that much. So we anticipate that we won't have to vaccinate like flu, but it's just going to be more like how long, does this immunity last?
I have another quick question for you about vaccines too. Why should we continue to take precautions if the vaccine is coming? And also, on top of that, say I get the vaccine or you get the vaccine, do I have to keep wearing a mask?
Right. So keep in mind that it won't be until probably May or June until we have widespread vaccination across Utah or the United States. Really depends on who you're looking at, who you're reading about, anticipation of when we're going to get through the 150 million people in the US that are at high risk for bad outcomes. Some people will say June, Operation Warp Speed says maybe April, May, but regardless, it's going to be a while. And so we know that we going to have a very large population that will be susceptible to this virus for months yet. Okay, and so because of that, the only way we have to control this virus is through public health means: social distancing, wearing masks, washing your hands. That's the only way we have to control this virus until we get a critical mass of people vaccinated. And so we're going to be in this public health domain for months yet until we can get the vaccination programs up where we get, the majority of people here in Utah vaccinated. It is true that, we're going to start vaccinating, and even small amounts of vaccination is going to help us in the hospitals, because we're going to go out, you're going to vaccinate the highest risk people. Those are the people that are most likely to get hospitalized. And so if we can do that, if we can effectively get to those people that are at highest risk, we can take the stress off the healthcare system, as we go forward. And that's really our hope, that we can do this really starting in January and February to really decrease that burden. But we're going to be stuck with public health measures until we can get widespread vaccination across Utah and the US.
And as far as a recommendation on who should actually receive this vaccine, I know healthcare workers and elderly and care centers are kind of at the top of the list, but who do you think kind of falls into that next category?
Yeah, so keep in mind that the CDC makes these recommendations the CDC makes the recommendations to the states, and then healthcare networks like Intermountain Healthcare is able to vaccinate people on behalf of the state. Okay, so Intermountain Healthcare is not making these determination of who gets vaccines, who doesn't. That's coming from the state, and we follow those state guidelines, and we're happy to vaccinate, as a partner with the state health department. Like you said, CDC has made recommendations, which we anticipate our state to follow, is that healthcare workers and also long-term care residents and workers will go first and kind of essentially phase 1A. What phase 1B looks like, we aren't 100% certain, but people that would fall into that category would be critical workers. So think teachers, first responders, grocery store employees, people that are really at the front lines of this. And then also people that will have a negative outcome if they get infected, those at highest risk for hospitalization or death. That's when they would start coming as well. And so I think that would be kind of the next kind of phase 1B after we vaccinated healthcare workers and long-term care residents and workers.
I want to switch gears a little bit to two reports that came out from the CDC. The first one I want to talk about is a report from Kansas that talked about a statewide mask mandate and the success of it. Will you explain what happened in this case study and what the results and findings were?
Yeah, really another great study coming out from the CDC. We've now said this for months, that the time to discuss the effectiveness of masks is beyond us. The science is clear. And this is just another study that really highlights how effective masks are. So this summer, Kansas was going through a pretty significant increase in cases. The governor of Kansas instituted a mask mandate for the state, but the county level of Kansas, at the county level, they could opt out of that statewide mask mandate as part of their constitution. And so what happened is you have this natural experiment of what happened at county to county levels based on whether or not they opted in or opted out of this mask mandate. Approximately 100 counties in Kansas opted in, approximately 80 counties opted out. And what happened is the counties that opted in to the mask mandate had a reduction in cases of approximately 6%. The counties that opted out of the mask mandate did not require masks, had a 100% increase in cases. And there wasn't any other, intervention at that time that could account for that difference besides the mask mandate. So counties with masks reduced cases by 6%, counties without masks increased by 100%. So another just really very well done scientific study to show that masks certainly work in terms of preventing the spread of infection.
I lied to you. I have one more question about the vaccine. This is a good one. Someone actually just asked us on the live, if you've had COVID-19, should you still get vaccinated?
Yeah, I think what's going to come from the CDC and what's already come from the CDC is that there's no requirement for serologic testing prior to vaccination. We are going to recommend everybody get the vaccine, regardless if you had COVID-19 or not. We don't know, it comes to the fact that we don't know what the immunity of, infection is compared to that of the vaccine. And so the recommendation is just everybody get it. The other kind of thought is it makes it so much logistically harder if you require a determination of whether you've been infected or not prior to even a vaccine. And we're trying to vaccinate 300 million people in the US. It's just going to be go out, give the vaccine to everybody.
Last question for you. The CDC also just released a report about shortening their quarantine length from 14 to 10 days. What does this mean for people, and the fact that you can test out of it? What does this mean for people who are infected with COVID-19, and how should we kind of take these precautions, and what should we be doing?
Yeah, so the CDC changed their policy on the quarantine period, not on the self-isolation period. So we need to make a distinction of this. So within the quarantine period, meaning you've gone out and you've been exposed to somebody that has active SARS-CoV-2. And so you've been exposed, but you do not have the infection at this point, okay? So prior to this, if you've been exposed, high-risk exposure, you had a 14-day quarantine period where you're supposed to stay at home, dramatically limit your social contacts, and wait to see if you develop symptoms. And we set that at a 14-day period because that's the incubation period of the virus. What this new guideline does is it shortens that duration from 14 days to 10 days. The reason they did this is that the majority of people that if they were going to get infected after an exposure would get infected before day 10. And so you'd have symptoms starting before day 10. And the reason they did this was to really lessen the burden on all of those people that have been exposed and are in quarantine. And so they can get out and actually engage with the community. And the fact that most states have a mask mandate, even if they had some early viral shedding before they develop symptoms, they're wearing a mask. And so it likely is not going to contribute to spread. So they moved it from 14 days to 10 days. Sorry about that. That's my dog.
Real life.
Real life, that's right. And so 10 days out, if no symptoms, you can come out of quarantine. If you develop any symptoms after day 10, by all means, you have to go back in quarantine and get tested. Now, they also put in a clause that they can test out of quarantine at day 7. So you go out, you get exposed, and you go out and get a test at day 7, as long as you're still asymptomatic. And if that test is negative, then you can get out of quarantine as well. So it's just two methods to really decrease the burden on people to reduce the effect of the quarantine.
Okay, last question, because this is a good one. Someone asked, to play devil's advocate, some would say we've had a mask mandate for nearly a month and we're still seeing a high rate of new infections. How do you respond to people who wonder if the mask mandate is actually working?
Yeah, so what we think and what we're hearing from the state health department is that we're seeing significant transmission in people's homes and social events that are located, at people's homes inside where people aren't wearing masks. And so, masks certainly help in terms of prevention of transmission of infection in the grocery store, at work, in these controlled environments where people are wearing masks. It doesn't help when people come into your home and you socialize with them in a enclosed setting without windows open, without masks. And so Masks absolutely work, and I would hate to see what our numbers would be without our mask mandate. Masks don't work when you don't wear them. Okay, so all those social events, all those gatherings that people are having without masks, that's where we're seeing transmission. Extracurricular activities, sporting events, all those things where people aren't wearing masks, that's where you get transmission and getting transmission in the home. So it's a really good question. We need to evaluate these, these things we put in place every single time we do them. So I think it's a great question for us to reflect on. But I would say, what do you think the counterfactual is? What do you think would have happened if we didn't have the mask mandate across the state of Utah? And I could tell you we'd be in a far worse situation than we currently are. And so it really is being driven by where we're seeing this transmission of virus.
That's something good to know. Yeah, the social gathering piece, you think you're safe around your friends and family, but you've mentioned this in the past, the bubble, if you expand it, you don't know what they're doing and what other people are doing. So it's always good to wear masks around even friends and family. So Dr. Stenehjem, thank you so much for joining us today. I really appreciate the update. And if anyone has any questions around COVID-19 and would like to see if they qualify for a test, you can go to intermountain.com/COVID testing and answer a couple of quick questions. If you do qualify, you'll be able to schedule for an arrival time at one of our sites, or you can also look through the state resources for other locations. We also have our emotional health relief hotline available still 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Thanks, everyone. We'll see you next time.